Good morning, everyone. Buenos dias, or olá. I'm Joana, a pediatric surgery resident from Portugal, and today I'll be talking about acute appendicitis or appendicitis aguda. This is one of the most common diagnoses we face in the emergency department, and we will cover it through a simple structure. You'll notice many questions in this talk, and that's intentional. The goal is to spark curiosity and help you remember and apply concepts you probably already know. So, what exactly is acute appendicitis? It is a progressive and irreversible infection and inflammation of the appendix, which, if left untreated, leads to perforation. Why does it matter so much? Because it's the most common reason for urgent abdominal surgery in children. It is diagnosed in about 1 to 8% of kids presenting with acute abdominal pain, and normally we have kids from 10 to 20 years old having this pathology. And to make this a bit more practical, will follow a patient through our presentation. So, we have a 10-year-old boy that comes to the ER with abdominal pain for 10 hours. The pain started around the belly button and then moved to the right lower quadrant. He has fever, 38.2 degrees, nausea and loss of appetite, no urinary symptoms, and just one episode of mild diarrhea, and no other complaints to add to these ones. So, what are the classical signs of acute appendicitis? Typically, pain starts in the periumbilical region, then migrates to the right lower quadrant. Childs might um, complain about anorexia and start vomiting after the pain begins, but not always, and sometimes the presentation is quite vague or the child just looks unwell. And to give you an example, I will show you an unusual case. We had a 5-year-old boy that came because of refused to walk. He complained about pain in his right knee, and he was seen by the orthopedic surgeon, by the pediatrician team, and an ultrasound was made of the hip and the knee. And while they were there, the mom told the radiologist, "Oh, look, my husband, the kid's father, had appendicitis as a child, and his only symptom was a knee pain." So the radiologist put the probe in his belly, and it diagnosed an acute appendicitis with a small abscess near the tip of the appendix. So just to show you, the classic signs do help, but we must always keep an open mind about how the appendicitis will present in the kids. On exam, we first assess the general condition of then the abdomen. We look for signs of distension in the belly, tenderness, and guarding. We may check for McBurney sign and some rousing or obturator signs. There are the classic ones that comes in the books, but not all will be present, and they can only guide us to have a clear picture of the physical exam of this patient. These are the several signs that I just spoke about, and they can support the diagnosis of appendicitis. Our 10-year-old boy was stable. He had good condition. He walked by himself and didn't have pain while walking. But when we pressed it, he had pain in the right lower quadrant. So at this point, the question is, what warning signs should we be watching for? We must never forget the red flags. It's very important when we have a child to recognize they are severely ill. So look for signs of shock, altered metastasis, persistent fever, or bilious vomiting, or any signs of peritonitis that can help us realize that that kid is becoming septic by the hour, and we have to manage it accordingly. What else makes appendicitis in kids? Well, most often we have gastroenteritis and mesenteric adenitis. They are the big two. But then some urinary causes, some inflammatory bowel disease, Meckel diverticulitis can be mimicking appendicitis, and we must never forget it. And in adolescent girls, it's good to remember about ovarian torsion, rupture cysts, ectopic pregnancy, and don't forget, some kids, when the age is accordingly, intussusception or severe constipation can be the cause of the kid's pain. Now that we've taken the history and done the physical exam and thought about the differentials, what should our next step be concerning our little kids? Well, it will always depend on the child we have in front of us. If the patient is clinically stable, we stop oral intake, give analgesic, and proceed with the additional studies that we have available. But if there are alarm signs or we suspect sepsis, then the priority is stabilization first, followed by the further investigations that we want to do. So, what are those other investigations that we can use to help us? Well, classically, appendicitis is a clinical diagnosis. In many cases, you don't even need labs or imaging before taking the child to surgery. That's what the books classically say. However, to avoid unnecessary procedures, now we have complementary studies that can support the diagnosis and just take the kids that need to go to the operating room, be the ones that have appendicitis. However, if we are uncertain and want to rule out infection, labs can be useful as a first step, but always remember that blood tests are not mandatory to diagnose appendicitis. For our patient, only a mild elevation of PCR was seen in the blood work. There are some studies that when we have high white blood cells and high PCR, it's very likely it's acute appendicitis, but we still need more studies to make a rule out of it. And when we thought about the next step, when I asked you guys, I think for any child that comes into the ER with abdominal pain, we think almost immediately about imaging when we think it's appendicitis or something like that. So that's why one of the most requested tools in this context is the abdominal ultrasound. But wait, in adults, we often use scoring systems to estimate the probability of appendicitis, but in children, what is our practice? Scoring systems like PAS or Alvarado score or even the newer PARC can help us stratify patients into low, intermediate, and high risk, but they never replace the clinical judgment. They are more of a support tools to guide whether we should get imaging or involve surgery early on the evaluating this child, but they are not mandatory, and usually it's the clinical signs and the clinical judgment that will decide if it is appendicitis or not. These scores don't replace what we need to decide on surgery for a child. So that's why we always come back to imaging, and this is the key step in guiding our decision usually. On ultrasound, the typical signs of appendicitis are, as you know, non-compressible tubular structure in the right lower quadrant, wall thickening greater than 2 millimeters, diameter over 6 millimeters, increased blood flow, and sometimes even freer fluid or appendicolite can explain to us what kind of appendicitis we have. So, in our patient, the ultrasound showed an 8 millimeter non-compressible appendix with a wall thickening and Doppel hyperemia. So that's consistent with acute appendicitis, as it was the diagnosis we were thinking about for our boy. If the child is stable and the ultrasound says it's not appendicitis, but we think the clinical signs, the pain just started, it's in the belly button, now it's starting to migrate to the right lower quadrant, we might admit to this child to observation to see how the pain goes in the next 12 hours. Or we can even think about repeat the ultrasound before we do any more invasive diagnostic techniques. And some selected cases here in Portugal, discharge is also possible in these cases. We give clear instructions for the parents to return if symptoms persist or worsen, and they oblige to these rules, and it's possible to send him home. So, one problem is when the ultrasound reports that no appendix is visualized. That's when we look after for the indirect signs, and depending on the case, we might repeat the ultrasound later, we might assume it's an appendicitis, or we might think we need another modality imaging. So, at what point do we consider a CT scan? Well, It is mainly used when the ultrasound is inconclusive or not available. It has very high sensitivity and specificity and can also reveal an alternative diagnosis. But the downside is the radiation exposure, which is why ultrasound and repeated ultrasounds are the preferred test in pediatric patients. In our practice here in Portugal, CT is most useful in children with high clinical suspicion but inconclusive ultrasounds or when obesity makes the ultrasound unreliable. So, let's come back to our patient. Given the history, exam labs, and ultrasound findings, we can say with quite a big confidence that it's really an acute appendicitis. So, what should be our next step? We want to treat it, right? I want to treat it, you guys want to treat it as well. So now let's move on to the treatment of appendicitis. The majority of children with appendicitis require appendectomy, but in some uncomplicated cases, non-surgical treatment with antibiotics can also be considered. How do we decide on which path to take? It will always rely on if it's an uncomplicated or a complicated appendicitis. In uncomplicated cases and in the complicated cases, one of the pillars of our treatment is appendectomy. It will always be an option no matter in what stage of treatment we are. For uncomplicated cases, a small subset of children may be treated with antibiotics alone. The drawback is the risk of recurrence later on. In complicated cases, surgery is usually required, but in some stable children with phlegmon or abscess without an appendicolite, conservative management with antibiotics and drainage can be chosen, followed by an interval appendectomy later. So, when can we consider not offering surgery at all? These kids will be the ones that have very good condition. We have an early disease. It just started a few hours ago, the symptoms. The family is reliable and there are no red flags such as no prolonged symptoms, no high inflammatory markers, no worrisome imaging. These ones we can offer them this. Otherwise, surgery will be the way to go. In non-operative management, we usually start with IV antibiotics for 1 or 2 days, then switch to oral therapy for 7 to 10 days. In our hospital, this is not standard practice. I've not seen one patient at all having this, but I know some cases in Portugal, some places they do it by standard and they have good results. Just for you to know, there is a study where they realize that about 1/3 of children that are treated with antibiotics alone will need an appendectomy within 1 year. So that makes us think. So, surgery remains the cornerstone of the treatment as we spoke about, but antibiotics are an important supporting role. The question is, when do we start them? Well, you should start them as soon as you make the diagnosis. As soon as you say it's appendicitis, you start antibiotics. For simple appendicitis, they are given as prophylaxis. In our practice, here in Portugal, we usually use cefoxitin, or in allergic patients, it's metronidazole and gentamicin. For complicated appendicitis, therapeutic doses are started most oftenly with ceftriaxone and metronidazole. And of course, for some patients that have been hospitalized recently, or if it's hospital practice, piptazo might be one of the antibiotics you start with, but it's very rare. And the allergic ones, you have to use another regimen. So when do you stop them? Well, it will always depend on the surgery and how the child recovers after the surgery. As we said, the cornerstone is laparoscopic appendectomy, and whenever it's possible, I think it's the best course of action. However, given the intraoperative findings, we might think about something different. In our experience, uncomplicated appendicitis, we stop the antibiotics after surgery. Many children can be safely discharged within 24 to 72 hours. If they are clinically well, the surgery was very linear, no complications. The appendix was an early appendicitis, those children normally go home in 1 to 2 days if the surgery was very at night or something like that. If the appendix is gangrenous or if there is spillage during the surgery, we usually keep the antibiotics for at least 24 hours. And we do it with ceftriaxone and metronidazole usually. In complicated appendicitis like abscesses or peritonitis, then we had already started ceftriaxone and metronidazole, and we will keep it after the surgery. For this less complicated appendicitis, or you can define it as no complications, you can think about discharging them in 24 hours if they are afebrile and if everything is okay. For complicated appendicitis with good progress, discharge is usually possible between the 4 and 7 days of antibiotic therapy. In our hospitals, some smaller abscesses often go home at day 5 if they are fine. And usually the generalized peritonitis, we say the parents that at least 7 days they will stay at the hospital. In these more complex cases, we monitor very closely, usually around 48 to 72 hours. If there is persistent fever, intolerance to food, or other signs of infection, we will repeat the labs and order some imaging if we think it's necessary, and pay close attention to the oral intake because this helps with healing. And if it's not adequate, we involve the nutrition team. Needing the more direct approach are the ones that are complicated with abscesses, and this is the most manageable complication, but sometimes you need to change antibiotics, and you must always remember that taking back the child to the operating room might be a necessary step in treatment, and one must not be shy of taking them back if that will change the course of progressive sepsis that they might have due to peritonitis. In our center, discharge is given once the child is afebrile for 24 hours, the bowel function is restored, the diet is well tolerated, and pain is controlled with oral meds, and the abdominal exam is benign. Always we have a follow-up. Some kids don't go home at 24 hours of no fever because they were started in large spectrum antibiotics, and normally the infectious disease recommends to do the standard time, and they will stay a bit longer in the hospital. Now, I will share with you another case. We had a patient, she was a 15-year-old girl who came after about a week of abdominal pain, and by then she no longer had fever. She was in good general condition, but the pain was still there and it was not getting better. She did an ultrasound that showed an appendicitis with an abscess. So, this is a child that she's okay 1 week, and this brings us to when should we consider not operating in cases of acute appendicitis with abscesses. Usually in children that are in good condition with a late presentation, more than 5 to 7 days when they come to the ER, and have a well-localized abscess or phlegmon, and they are started on antibiotics, and you have availability of percutaneous drainage with a radiologist, we can consider it for abscesses that are larger than 3 to 4 centimeters. Usually when they are smaller, maybe we will operate on them, or maybe we will try just antibiotics to see if they resolve the abscess. When we have these patients that we propose the drainage, usually the discharge will be once the pain is improving and the child has no fever and he's in good health and good condition to go home. These patients will still need surgery, and we always tell the parents that the course of the treatment will be we can start antibiotics, we will drain the abscess, but in some time in the future we will go and take out the appendix. And when parents ask when, I like to say about 10 to 12 weeks. It's a good place to start with and to give the parents that time. So, coming back to our 10-year-old patient, we proposed laparoscopic appendectomy. We stopped the oral intake, started the prophylactic antibiotics with cefoxitin, and gave pain control. We were able to have a room to operate on him in like 12 hours of him being in the OR. The surgery showed a retrocecal appendix with suppurative appendicitis and only a small amount of serous fluid. The appendectomy went smoothly, and 24 hours later, the child was discharged home. But we had to tell the parents something to look for, because in the days after the discharge, some complications might appear. So, what is the most common one? It's usually wound infection that we can manage with local care. Um, Intra-abdominal abscesses are especially frequent in complicated appendicitis, and there are other complications that one must be alert the parents for. And you can never forget about the stamp appendicitis. It's something that happens, although it's very rare. That brings us to the end of our 20 minutes. I hope you had this was useful and you had a good time. Remember, acute appendicitis is one of the most frequent conditions we face, and ranging from something very straightforward to something much more delicate. Our expertise in leading with these cases will grow as we grow as well in the pediatric surgery world. So, you have here my email. If you have any questions, you can ask for it. And thank you very much for your time.